So hello, everybody. My name is Miron. I'm the Policy Director of Cal Voices. Welcome. Just a few housekeeping. My colleagues Jocelyn and Farrell, Grace Gallagher are going to join today's meeting. I need to move this thing. Sad. After each presentation, we'll have time for discussion. Jocelyn and Grace will monitor the screen and the chat box for comments or questions. The opinions expressed in this presentation are of Access and not OIC. So we'll have the agenda. We'll have two parts. One will deal with Cal Voices budget priorities, and part two will talk about Cal Voices legislative priorities. We'll have time after every presentation. Like I said, we'll stop for your question. So just an introduction. Each legislation session introduces hundreds of bills, many of which impact the behavioral health sector. At Cal Voices, we, along with our partners, review these bills to identify which initiative to support or oppose, actively engage the community on significant legislation. Cal Voices advocates for increased public funding for behavioral health services to support community-based initiatives rather than relying on institutionalization or the expansion of law enforcement. And the next hour, I'll outline some of Cal Voices' legislative priorities for the 2025 and 2026 sessions and discuss two budget priorities for the 2025 and 26 fiscal year, aiming to spark community discussion on future legislative efforts. So the part one, we'll talk about Cal Voices' two budget priority. So key deadline for the state budget: on and before January 10, the governor must submit a proposed budget to the legislature. The governor updates the state's budget proposal in May, reflecting the updated economic forecast and adjustments. The legislature review the governor's proposal and holds hearings in the Senate and Assembly budget subcommittees to examine the details of the budget and solicit input, public input and feedback. The legislature must pass the budget bill on or before June 15th and send it to the governor for approval. So the governor can sign it, veto it, or allow it to become law without a signature. So in this fiscal year, Cal Voices prioritize and they may revise, the governor may revise propose to eliminate $20 million in ongoing funding allocated for the Mental Health Wellness Act program, which is administered by the Commission for the Behavioral Health. It's proposed using a $20 million innovation-related grant for Proposition 1. So the Mental Health Wellness Act is part of the Commission's local assistance budget. That means it is designed to serve unmet needs in local communities. So transferring this fund to the general fund would have stripped critical resources away from the California most vulnerable population. Sorry about this. So the proposed May revised would have, in terms of the short term, there is short-term and long-term impact. The short-term impact would have eliminated 3 programs that are each with $20 million. And that is, the first one is $20 million grant for children age 0 to 25 to be awarded 6 to 6 community-based organization and 1 technical assistant provider. So eliminating this fund would deprive organizations of the resources needed to support individuals during pregnancy, infancy, and early childhood. Another program was in pipeline, was ready to go, was $20 million full service partnership. And that was developed in collaboration with the state and local partners to ensure alignment and enhance the capacity for technical assistance. Of course, another 20 million peer respite grant. This was ready to go. The peer respite are voluntary, short-term residential program designed to support individuals experiencing or at risk of a psychiatric crisis. Peer respite provide dignified, voluntary alternatives to hospitalization, offering compassionate support to individuals in crisis. So the long term of that the governor proposed would have impacted the effectively eliminate all the commissioned grant program, while a new $20 million that the governor proposed, which would have come from the innovation-related grant funded by Proposition 1, but that was short term, is only for 5 years. That means after that amount was used, the commission will have to try to secure additional funding. So in order to reverse the May revised proposition relating to the Mental Health Wellness Act, CalVoices spearheaded a coalition of the sign-on letter and submitted to the Senate Assembly Budget Subcommittee on Health. We attended the Senate and Assembly budget hearings and provided public comments in opposition, worked closely with the commission staff and partners to coordinate legislative advocacy to reject the governor's proposal to eliminate the Mental Health Wellness Act. The status, so in terms of the status now, we're happy to report the California legislature released a budget on June 9th, rejects the elimination of $20 million from the Behavioral Health Service Fund supporting the Mental Health Wellness Act. They redirect the Behavioral Health Service Fund to allocate 10 million additional for Mental Health Wellness Act resources at the Commission for Behavioral Health, of which 5 million will support substance use disorder youth program. It also redirect 20 million Behavioral Health Service Fund ongoing to support the Mental Health Wellness Program at the Commission on Behavioral Health. This is a huge success. Unless the governor vetoes it, the Mental Health Wellness Act has dedicated funding. This is a good example that demonstrates how advocacy through collaboration yields the correct results. Of course, we did all the work through partnership. All the partners are listed, Painted Brain, Mental Health America of California, but since this PowerPoint presentation will be available to you, you will be able to review all the partners who work very hard to make this happen. Question, discussion? Grace will help me if there's any question. Do you see anybody, Grace, Jocelyn?
No questions in the chat yet.
Okay. So the second budget request that we prioritized is the peer personnel training and placement program. So just to give you a background information, for an outside sponsored budget request, there must be a legislator to sponsor it. So in this case, Senator Laura Richardson agreed to sponsor this budget ask. We're extremely grateful to her and her staff. The objective is a request of the California state legislatures for a dedicated fund of $14 million yearly for the peer personnel training and placement program. So the program is administered by HCI through the Workforce Education and Training dollar from the MHSF, now it's known as BHSA fund, and other supplemental funds. What is the significance of the program? The program is to build and support a behavioral health workforce through partnership with public, private, and nonprofit organizations. So since 2014, it has supported 14,873 peer personnel. The fund helped to recruit, train, and place peer personnel into position where they can provide essential support to clients, families, and caregivers. So by ensuring that participants complete the training, the program opens doors to immediate employment opportunities and fosters career progression. So in order to secure this $14 million yearly, some of the budget advocacy activity that we had done, we formed a coalition that comprises previous grantees of the program. We prepared a budget and met with the staffer of several Senate and Assembly members to secure a sponsor and advocate for 14 million in dedicated funding for the program. So as mentioned above, Senator Richardson was instrumental in advancing our request. We also met with the governor's office. We sought to help from the peer community to contact their state legislatures in support of the budget ask. So the status, the legislator did not include the 40 million dedicated budget we requested. While that is disappointing, we have every intention of regrouping to craft strategies early on and secure funding for this critical program. We will come to you for your collaboration. On a positive note, HCI receives $2 million annually from the BHSA fund in the budget. They have additional funding to support organizations that train peer support specialists through the BH Connect community-based provider training program, which will be launched in early 2026. The legislators also included 190,200,000 in 2025 and 26, which also include 28,500,000 BHSF from 2026 through 2030. That means we believe the peer personnel training and placement program will be funded through the available funding sources. However, our goal is to establish dedicated funding for the program to strengthen and expand it. Partner for the peer personnel training and placement program budget ask is Painted Brain, Disability Rights of California, Mental Health Association of San Francisco. All this were part of the grantees. And so Naomi San Diego, Imperial Counties, Mental Health America of California, SHARE, the Wellness Center, Mental Health Support Organization. So while we did not succeed in this fiscal year, we are already in the process of regrouping to start getting the sponsor early on and get the buy-in from the legislators early on. Question?
Michael has a question.
Hi, Michael.
Hi. In one of your previous slides, you mentioned something about partnerships with the private sector.
So you're talking about for the commission funding?
Yes.
Yes.
And I was wondering if you could talk a little bit more about that, like who are the private sectors involved, what have you done, and things like that.
Well, so we are, advocated for that $20 million was about to be eliminated. In terms of the, private entities that the commission work with, I'm not privy to that, but I can look into that and get back to you. I'll be happy to do that.
Thank you.
Of course. Any other question? So part 2 of our presentation will focus on CalVoice's priority bills. So I think some of you already know about AB 96, but for those of you who haven't had any chance to listen about it, I'll go through it. AB 96 is sponsored by CalVoices and authored by Assemblymember Jackson. It would expand the definition of the community health workers to include a peer support specialist. This means, in addition to medical billable peer support services, peer support specialists would also be able to provide medical billable CHW services without having to acquire and maintain a separate certification. So this is an important component of the bill. In addition to county-administered SMHS and DMS program, peer support specialists would be able to work in the MCP-administered ECM program. Just to provide a quick background, as you know, all medical managed care plans must offer CHW services under the CALEM Enhanced Care Management benefits as mandatory benefit, and the state funds the non-federal cost share. Cover CHW services are listed here: health education, health navigation, screening and assessment, individual support or advocacy. This include peer support, but if it's not duplicative. I think the minimum qualification to become a CHW include lived experience that align with and provide a connection between the CHW, a member, or the population being served. This may include also mental health condition or substance use disorder. There are two paths to becoming a CHW under the certificate pathway and a work experience pathway. So CHW certificates has not yet developed, but they allow a valid certificate of completion of a curriculum that attests to demonstrate skills or a practical training in areas such as communication, interpersonal, and relationship building. They also have under that certificate program, violence prevention professional certificate. Another pathway that I have is work experience pathway. This is for a person with 2,000 hours of CHW experience, paid or volunteer in the past 3 years, validated by the supervising provider, can provide CHW services without a completion certificate for up to 18 months. They must earn the certification within this period. Peers are omitted. So DHCS does not give PSS a CHW work experience pathway. So according to the old plan letter 24006, CHW can provide services to members with mental health and substance use disorders, but this do not include peer support services. So AB 96 addresses the workforce shortage. According to the UCSF study commissioned by the County Behavioral Health Director Association of California, behavioral health professionals do not reflect the racial or linguistic diversity of the clients served. They are aging. So the study recommends expanding the state's peer support specialists as a statewide medical benefit rather than a self-funded county option. HCI also reported, dated August 28, 2024, on the statewide shortage across all the behavioral roles. The finding shows that racial representation of providers is imbalanced relative to the population. They recommended a multi-pronged approach to support the behavioral health workforce, including funding peer and mentor network for behavioral health professionals. So as all of you know, CHW and PSS serve similar population: individuals experiencing homelessness, individuals with high utilization of emergency room services, individuals with serious emotional disturbance, serious mental illness, substance use disorder, etc. So what AB 96 does is it would give PSS a certificate pathway to serve as CHW to provide preventive services by recognizing the medical peer support specialist certification. Just like you see on this screen, there are two pathways. And so what AB 96 would do, add medical peer support specialist certification, and we be recognized to provide CHW preventive services. We have offered amendment to AB 96 to really limit the scope of the peer support specialists. So they would have direct lived experience of a mental health condition or substance use disorder, and they serve individuals with mental health conditions and substance use disorders. AB 96 align with CALEM's initiative. It would qualify PSS for CHW preventive services aimed at ECM focused population. At the county level, PSS serve medical enrollees with complex behavioral health needs by providing person-centered care that enhances access to services and improve health outcome. Per the State Plan 240052, enhanced CHW services are tailored preventive services for beneficiaries with significant behavioral health needs. PSS certainly have the training and experience to help the state avoid costly hospitalization by integrating into the CHW workforce and providing CHW preventive services to individuals with significant behavioral health needs. What AB 96 does not do would not change the meaning of or evidence base for behavioral health peer support services, would not alter any statutory provision in SB 803, would not modify the state's existing guideline for peer support specialist certification or the delivery of medical peer support services, would not allow CHW who are not also certified medical peer support specialists to provide medical peer support services. Some might ask, why not just expand peer services? We initially proposed two legislative methods of expanding medical peer support services. One, we wanted to amend SB 803 to make peer support services mandatory rather than optional, as it is the case now, in county administered SMHS and DMC program. Or we said, make medical peer support services an included benefit in medical MCP programs, such as enhanced care management, community support, and non-specialty mental health services. Both proposals were declined by the legislators for fiscal reasons. So currently, the bill is a 2-year bill. And some of you might ask why the bill is a 2-year bill, meaning that it will be picked up in the next legislative, and then in 2026. The reason we have decided to make this a 2-year, because we have heard some concerns from the California Pan-Ethnic Health Network and the County Behavioral Health Director Association about AB 96. CalVoices is planning to organize a roundtable-like discussion involving key stakeholders to A, listen to the concern some stakeholders have relating to AB 96 and explore solutions, and B, discuss options other than AB 96 to enable PSS to provide services in non-specialty mental health services. We plan to fully involve the peer communities throughout the process, as your support is essential in advancing any policy change. To conclude on this particular bill, AB 96 is a timely and effective bill that would expand peer support specialist employment opportunities beyond county administered behavioral health program. CalVoices is committed to exploring every possible policy option to integrate PSS across the continuum of behavioral health care. AB 96 enjoyed support from various organizations. As I previously said, this PowerPoint presentation will be available. So then you will be able to review the list of support for AB 96. Questions, discussion?
Dawn?
Hey there.
Hi.
I was curious about the statement peers are omitted. I think it was back on slide 30 or so from the work experience pathway for CHWs. I didn't quite.
Department of Healthcare Services does not give, does not recognize peer work, as a pathway to allow them to work as
Oh,
a
it doesn't,
CHW for 18 months.
it doesn't include the peer
It
work.
excludes them.
Okay. But if they happen to have CHW,
Of course,
then-
absolutely.
okay.
That
Okay.
means they have to get a different certification. Absolutely.
Gotcha. Thank you.
Of course. So SB 331 is authored by Senator Menjavar. It's one of the bills Cal Voices is working on in opposition. The bill is sponsored by the California State Association of Psychiatrists and authored by Senator Menjavar. The main provision of the bill, so one, for the CARE Act process, the bill permits an original petitioner, could be a family member or someone who lives with the respondent in accordance with the statute, to participate in developing care agreement and plan if the respondent consents. The second provision which we oppose is it defines mental health disorder as any condition outlined in the current DSM for the purpose of LPS Act. What is the existing law? The legislature passed the LPC Act in 1967 to end institutionalized mental health care and comply with federal law. They assigned counties the responsibility of providing mental health services. The legislature intent in passing the LPS Act is to place individuals with severe mental health condition in the least restrictive setting appropriate for their needs. The LPS Act to self and gravely disabled because of a mental health disorder or a severe substance use disorder as defined in the DSM to be involuntarily detained for involuntary treatment. SB 331 sponsors explained that, the California State Association of Psychologists, Dr. Meyer, the lead person, in response to the need for the bill said, currently, individuals with major neurocognitive disorders are restricted from inpatient psychiatric hospitalization. They said only those with delusions or suicidal ideation are permitted entry. This leaves, according to the sponsor, out major neurocognitive disorders with behavioral disturbances from appropriate level of care. Cal Voices concern on SB 331. So the current law does not define mental health disorder in the statute or regulation. The LPS Act does not elaborate on what it means to be a danger to oneself or other. SB 331 attempts to define mental health disorder as any condition outlined in the DSM, which would result in a significant and inappropriate expansion of the type of condition that could fall under LPS. The most recent version of DSM lists 277 conditions, including developmental disability, substance use disorder, caffeine use disorder, restless leg syndrome, etc. This is one of the most expansive lists of characteristics provided to police, clinician, designated facilities to justify forcefully institutionalizing individuals. So Cal Voices' concern, we believe, placement of individuals on hold involves the person being taken to a locked facility, mental health hospital or chemical dependencies recovery facilities, to designated for LPS hold. Using the disorder listed in the DSM to define mental health disorder would include people with neurocognitive disorders, including Alzheimer's disease, dementia, to be considered for an LPS hold. According to the county, which we are working closely with the County Behavioral Health Director Association, the county behavioral health does not have the right expertise to address neurocognitive disorders. So, in order to defeat SB 331, some of the advocacy activities that we engaged include: we met with the Senate Health and Judiciary Consultant to share concern. It was double referred. Met with the sponsor to offer an amendment to remove the provision that defined mental health disorder, which they rejected. We submitted an opposition letter to the policy committees and testified and provided me to an opposition, strategized with our partners, and sent the opposing sample letter out to the peer community to use as a template to submit to the Senate Health Committee and Judiciary Committee. Status of SB 331, unfortunately, it went through the whole entire Senate House. The bill passed the Senate floor and is in the Assembly. We are planning to expand our coalition to fight against the enactment of SB 331 in its current form. Our position, as I said before, is to seek an amendment to remove the provision that defines mental health disorder. The state must stop passing bills that focus on involuntary treatments that are costly and ineffective. We will come to you to ask for your engagement in the coming days. We work, as I said, very closely with the County Behavioral Health Director Association of California. This is an important bill, and they have a high stake in this. We work with CAMPRO, Disability Rights California, Mental Health America of California. Any question? Okay. So AB 416, involuntary commitment. So this bill is sponsored by the California chapter of the American College of Emergency Physicians. So before being amended, AB 416, as published on 02/5/25, would have allowed all emergency physicians to write a 5150 hold. What is the existing law? WIC 5150 authorizes some behavioral health professionals and all police officers to write involuntary 5150 holds when a person is deemed a danger to self, a danger to others, and gravely disabled due to a mental health disorder or severe substance use disorder. 5150 hold allows a person to be involuntarily detained for 72 hours, including to transport that person to an LPS designated mental hospital. The LPS Act authorizes licensed behavioral health professionals who work in an LPS designated facility to place holds in the course of their employment for that facility. Emergency rooms can be LPS designated, but many are not. So licensed behavioral health professionals who work in emergency rooms can be designated by their county to place holds, even if they work at a non-designated facility. So AB 416 sponsors explanation for introducing the bill. The sponsor argued that many hospitals lack LPS designated individuals on staff. They say if EP believes that a behavioral health patient is a danger to themselves or others, they must contact the county and request that a designated individual place the patient on a 5150 hold, they say, which can take 12 to 24 hours or even a few days. CalVoice's position on AB 416 as published on 02/05/2025. Our coalition position was to require ER physicians to go through the county behavioral health director's procedures for the county's designation and be certified to write a 5150 hold in county designated facilities. We felt exempting ER physicians from going through the county's designation process for a 5150 hold would have fragmented the behavioral health system, reducing coordination between providers and counties. So as most of you might know, the county behavioral health director procedures for the county's designation and training of professionals to perform functions under Section 5150 include overview of license type, practice discipline, clinical experience required for professional designated by the county, initial and ongoing training, testing requirement for eligible professionals, the county's approach to monitoring and reviewing designated professionals ensure adherence to the state laws, regulation, and county procedures. So as part of the opposition to AB 416, CalVoices, along with partners, we met with the Assembly Health Consultant to share concerns, discussed concerns with the sponsor of the bill, submitted an opposition letter to the Assembly Health Committee, strategized with our partners, and sent the opposing sample letter out to the peer communities to use as a template to submit to the Assembly Health Committee, testified, provided me to during the Assembly Health Committee hearing. The status is AB 416 has been, after extensive negotiation, AB 416 was amended on 05/7/25 to read, a county behavioral health director is to include an emergency physician as a professional who is eligible to be designated by the county when developing and implementing procedures. ER physician would have gone through the training, application, and approval process as all professionals must to be designated by the county. That was exactly the amendment we wanted to happen. So the amendment satisfied CalVoices in our coalition, allowing us to change our position from opposing to neutral. We certainly appreciate the sponsor for working with us to address our concern. We worked with partners on, to have this AB 416 amendments, disability right. They are listed here, Disability Rights of California, but you will have a copy of this PowerPoint presentation. Therefore, you can see all our wonderful partners. We do everything in collaboration, as I said before. Any question? SB 823. Okay, Michael.
Yeah, the legislation addresses certifying personnel at the emergency to give them the authority to impose the 5150 hold. Yes.
Yes.
So I was wondering.
Yes, sir. Yes.
Yeah, I was wondering. I don't know if it's even related to this legislation, but there has been increasing reports where law enforcement officers is being brought out to the site where the client is at. Some of the law enforcement or some of the sheriff's department that I hear is that they are even reluctant to go out to address a mental health crisis, and least of all, even be in a position to impose a 5150 hold. And I was wondering, how is that being addressed?
So CalVoices' position is that our preference is that peer-led organizations and peer community-based organizations should be the one to provide services to individuals who are experiencing crisis. We don't necessarily agree that it is the job or the training for the law enforcement to respond to crisis that relating to behavioral health. And so I'm not sure exactly the particular incidents that you're referring to, but in general, what we focus on and what we would like to see happen is investment in community-based organization so that individuals with crisis have access to go to.
Okay, so our position is to have peer services involved in attending to these calls, and then it's only when they are being transported to the emergency, then the person that's being
Yeah.
licensed. Okay, got it.
Currently
All right,
licensed.
thanks.
Of course. So SB 822 Stern is a Mental Health and Care Act. So SB 823 would have expanded the care court eligibility to include individuals with bipolar 1 disorder. Existing law is, just to provide some background, the CARE Act was created through SB 1338, Umberg, 2022, and was implemented through two cohorts. Cohort 1, it was implemented on October 1st, 2023, included 7 counties, and Cohort 2, the implementation began on December 1st, 2024, and included 3 counties. Under the CARE process, a person is eligible if 18 years old or older, experiencing a serious mental health disorder and has a diagnostic of other psychotic disorders as defined in the most, DSM, and must be associated with social or occupational dysfunction and have a duration of at least 6 months. Be unlikely to survive safely in the community without supervision, and their condition is substantially deteriorating, or need services and support to prevent a relapse or deterioration that would be likely to result in grave disability or serious harm to self or others, resulting in involuntary detention. So it excludes psychotic disorders that are not primarily psychiatric. The CARE Act authorizes county behavioral health agencies and other specified adult person to file a petition to initiate CARE Act proceedings. The CARE Act does not mandate forced treatment itself. In fact, care could be the least restrictive alternative to facilitate the person's recovery and stability. However, respondents subject to the CARE Act are subject to conservatorship proceeding if they fail to comply with court orders. A court can order a respondent to follow the care plan for up to 12 months, with the possibility to extend for an additional 12 months. So Call Voice's concern on SB 823 is the bill would have significantly expanded the eligibility criteria for the CARE Act program by including individuals with bipolar 1 disorder, which is currently excluded. The CARE Act involves involuntary commitment that subjects individuals with complex and mental health conditions to a lengthy court process and is costly for the state. It diverts resources from community-based behavioral health services that foster voluntary engagement. So, as part of our opposition to SB 823, Call Voices closely worked with partners to submit a letter outlining our concerns, coordinated with our partners to assign witnesses with lived experience in opposition at the Senate Health Committee, met with the Senate Health Committee consultant and Senate member staffer to register our opposition. The status of SB 823, the bill was analyzed for fiscal impact in the Senate Committee on Appropriations. The analysis stated the bill would have impact on the state and county behavioral health department's general fund. It's now placed on appropriation suspense file. That means the legislator has made a decision not to move the bill forward. We just want to bring it to your attention, which is a great news. CalVoices opposed SB 1338, which created the CARE Act, because we felt it was too coercive and diverted funds from voluntary community-based services. According to the Department Healthcare Services report in November, I just want to give you some background about the update report on the CARE Act. In November 2024, 557 petitioners were filed, of which 217 were dismissed and 300 received care. So outcome will be released by July 2025. California spends close to $300 million annually on the CARE Act. Just to serve this 340, we don't even know the outcome of it. We think it might be time to reevaluate the fiscal feasibility of investing in the CARE Act. Partners on SB 823, California Peer Watch, CAMPRO, Disability Rights of America, Mental Health America of California. I cannot emphasize enough the importance of our work, collaborative work with all our partners, including the peer community. Questions and discussion? If you don't have any question or any comments, okay. Thank you for attending Access Legislative Update. If you wish to follow up with questions and suggestions, please get in touch with me at m.agonifer@calvoices.org. We invite you to join us in the next Access Legislative Update. Michael.
Sorry, I am kind of new to all this, and I just I was thinking about something, and it might be completely silly,
That's
but
okay.
now that we're relying more and more on peer support specialists going forward, is there gonna be room in the budgets, if something were to happen, right now, I'm a certified one, and the wages aren't necessarily the best everywhere. If the peer support specialists start unionizing or something and asking for more money, is that gonna if something like that happens, because every other healthcare professional have unions in California, if something like that happens, would that really affect, or could you, I don't know, it was just an idea that kind of popped in my head. How would that affect something, because it's something that I could see happening in the future?
I think currently, I think, it's negotiated and paid by county to a county. But in terms of to address your question, I think we should be open to explore work collaboratively and bring all the peer community together to advocate for increase of wages for peers. I think CHW have done it. We should be able to do that. I think it's a brilliant idea, and I will definitely propose your idea to my boss and see what we can do.
Thank you. I appreciate that.
Of course. Anyone has any question?
I have one question and statement.
Hi, Robert.
Sorry I was late. I was putting out fires today with some members that are linked to different managed care plans. But
Aw.
I like Michael's question, but so the way that things are moving with regards to MHA and BHS Proposition 1. So the way the funding is moving. So just recently, I'm sure everybody has been aware that the new movement, which I tried to start this initiative a whole year and a half ago, was that all peers also embrace the core competencies as community health workers. So they have both skill sets. So there wouldn't be even be a discussion about the wages. Whatever that community health worker makes, basically the new role would be you as a peer and the core competencies, you would be a enhanced community health worker, whether you're a community health worker or a peer, as long as you have both of those skill sets under your belt.
Interesting idea.
So they call it ECHW, enhanced community health worker.
So, as far as for enhanced care, we feel strongly because it's focused on individuals with severe behavioral health. Peers already have the training and the capacity to do the work. And in fact,
Absolutely.
we submitted our comment to Department of Healthcare Services exactly saying that peers should be able to provide enhanced care services at the county level.
You're absolutely
fact-
right.
In fact, it's a fact that CHW don't have the credential, appropriate training to provide that service currently, and PSS do. And so that's our position. We submitted that, and we are in discussion with the Department of Healthcare Services to make that happen.
Well, you already know they don't play fair. So, and as long as we're in the fight, that's fine. But until we win the fight, we might as well have both skill sets.
Interesting thoughts. Thank you for
Because
that.
I have all my staff are ACEs Aware certified. They can screen for trauma. They are all certified peers, and they have all the core competencies and the 2,000 hours for community health workers. So there's nothing that the agencies or the state say in that scope of practice in both lanes that they can't do. And they don't have to worry about the wage adjustment because they have both skill sets. So as a peer, I just advise that we equip ourselves. Not that's all.
So it's up to each individual to
Correct.
make a decision how they wanted to enhance their, their capacity. But we
Yep.
feel that peers have the knowledge, the training, the experience, and the willingness to do the work they're trained to do, and they should be able to do that. And that's where our focus is. But I understand your thoughts and suggestion, Robert.
Everybody have a great day. Wonderful weekend. Happy Father's Day.
Are we done? Happy Friday, guys. Thank you so much for coming.